Welcome, friends. Today we are going to learn some of the contributions given to the field of medical science by the great German surgeon Friedrich Trendelenburg, the name which is synonymous with the Trendelenburg sign, test, and gait. The hip joint can be considered an equivalent to a lever system wherein we have a load, a fulcrum, and an effort. The fulcrum is supposed to be the center of the femoral head. The body weight can be represented as the load applied to a lever arm extended from the body's center of gravity, that is just anterior to the second sacral vertebral body, to the center of femoral head. The effort is represented by abductor musculature or abductor tension acting on a lever arm extending from the lateral aspect of the greater trochanter to the center of femoral head. As we can see in this pictorial diagram, that because of the length of the ratio of the lever arm of the body weight to that of the abductor musculature is in the ratio of 2.5:1, the force of the abductor muscles must approximate 2.5 times the body weight to maintain the pelvis level while standing on one leg. Now, a problem with either the fulcrum or the lever arm or the effort would lead to a diseased hip. For example, failure of the fulcrum occurs in osteonecrosis of the hip, in Perthes disease, in conditions like developmental dysplasias of the hip, or in patients with chronically dislocated hips that could be secondary to trauma or infections like tuberculosis of the hip. Now, conditions in which there could be failure of the lever arm would be avulsion injuries of the greater trochanter of the femur, non-union of the neck of femur, and conditions like coxa vara of the hip. Conditions wherein there could be a failure of the effort, that would be the abductor musculature or abductor tension, could be seen in conditions like poliomyelitis, L5 radiculopathy, superior gluteal nerve damage, gluteus medius and minimus tendinitis or abscess, or post total hip arthroplasty. The prerequisites for doing or eliciting the Trendelenburg sign are: the pathology should be painless, there should not be any abduction or adduction deformity of the hip, because in an adduction deformity there would be elevation of the pelvis leading to a false negative result, and in presence of an abduction deformity there will be dropping of the pelvis on the contralateral side leading to a false positive result. Now, when a person stands on a single leg, the opposite pelvis is either stays level or it is pulled upwards because of the contraction of the ipsilateral gluteus medius and minimus. That is a normal or a negative Trendelenburg sign. Now, if a person stands on a single leg but the opposite, the contralateral pelvis drops, that is a positive Trendelenburg sign. That could be because of the problem of the fulcrum, failure of the fulcrum, or failure of the lever arm, or failure of the effort in the form of abductor musculature or abductor tension. This sign was described by Friedrich Trendelenburg in the year 1897 to identify hip abductor weakness in individuals with congenital dislocation of the hip and progressive muscular atrophy. This is a 6-year-old girl. When she is made to stand on the normal side, you can see the contralateral pelvis is being pulled upwards. And now when the patient stands on the affected side, you can see the contralateral pelvis drops. This is a positive Trendelenburg sign. Here the patient is made to stand on the affected leg for a minimum of 30 seconds. The Trendelenburg gait is an abnormal gait which results from a defective hip abductor mechanism. The two abductor muscles being gluteus medius and minimus. The weakness of these muscles would cause drooping of the pelvis to the contralateral side while walking. This is a 6-year-old girl who is walking with a Trendelenburg gait. Here the affected side being the right side. You can see during the stance phase on the right side, there is a drop of the pelvis on the contralateral side. The patient is compensating for this pelvis drop by lurching the trunk towards the affected side, that is the right side. When the pathology is bilateral, the pelvis droops to the unsupported side, alternating with each step, and is called a waddling gait. For varicose veins, we have the Trendelenburg's test, which is performed to determine the incompetency of the sphenofemoral valve and the communicating system. The test is performed in two ways. First of all, the patient is placed in a recumbent position and his leg is raised to empty the veins. Then, the sphenofemoral junction is compressed with the thumb of the clinician, or a tourniquet is applied below the sphenofemoral junction, and the patient is asked to stand up quickly. In the first test, the pressure is released. If the varices fill very quickly by a column of blood from above, it indicates incompetency of the sphenofemoral valve, and thus this test is called as Trendelenburg's test positive. In order to test for the communicating system, in the second scenario, the pressure is not released but maintained for a minute. If there is gradual filling of the vein during this period, it indicates incompetency of the communicating system. We also have a Trendelenburg operation in which we do ligation on the great saphenous vein, done for the treatment of varicose veins. There's also a Trendelenburg's position in which the patient lies supine on the operating table with their head declined below their feet at an angle of roughly 16 degrees. This Trendelenburg's position is used most commonly for lower abdominal surgeries and central venous catheter placements. There's also an instrument after the name of Trendelenburg, the Trendelenburg cannula and cone, which is used to prevent aspiration of blood during surgical procedures on pharynx, larynx and oral cavity.